CVS Part 1 Case 13.
A 58-year-old woman with a body mass index of 42 presents to the emergency department with progressive dyspnea over 2 weeks, now occurring at rest. She reports orthopnea requiring 3 pillows, paroxysmal nocturnal dyspnea and increasing lower extremity edema. She denies chest pain, fever or cough. Her medical history includes hypertension, diabetes, obstructive sleep apnea and chronic kidney disease stage 3. On examination, she appears distressed and diaphoretic. Her blood pressure is 88/56, heart rate 112, respiratory rate 26 and oxygen saturation is 90% on room air. JVP is elevated at 14 centimeters of water. Cardiac examination reveals S3 gallop. Lungs demonstrates bilateral crackles. There is 3+ pitting edema extending to the thighs and her extremities are cool with delayed capillary refill. Laboratory investigations include creatinine 2.4, sodium 130, troponin mildly elevated, B-type natriuretic peptides that is BNP is 85 which is low and lactate is 3.2. Chest radiography reveals pulmonary edema. Bedside echocardiography demonstrated left ventricular ejection fraction of 22% with global hypokinesis and a dilated left ventricle. Hemodynamics measurements via pulmonary artery catheterization shows elevated central venous pressures and PCWP which is elevated. Reduced cardiac index, elevated SVR, reduced mixed venous oxygen saturation. She is started on vasopressor support for hypotension. Which of the following best explains the unexpected normal BNP levels in this patient despite clear evidence of cardiogenic shock? Option A. Reduced myocardial synthesis of BNP due to impaired ventricular stretch signaling. Option B. Increased renal clearance of BNP in obesity. Option C. Analytical interference from circulating muscle-derived proteins. Option D. Enhanced clearance and sequestration of natriuretic peptides by adipose tissue. Option E. Cytokine-mediated suppression of BNP release in systemic infection.
So, this is a case of acute decompensated heart failure with cardiogenic shock. The hemodynamic parameters are clearly indicating a cardiogenic shock here, but the BNP levels are misleading. So, there are two key clinical insights in this case. First thing, that estimation of BNP is a diagnostic limitation in certain cases, like in some cases of heart failure with preserved ejection fraction. Second, in some cases of acute heart failure. And third, in obese individuals with high BMI, where the adipose tissue is sequestering the BNP and leading to a falsely low value. So, we have to understand that why this BNP gets secreted. Now, we have already mentioned that it's a decompensated heart failure, means the heart failure is trying to get compensated by the activation of the neurohormonal compensatory mechanisms like activation of the sympathetic nervous system and other mechanisms, but it's not getting compensated by that. So BNP further is released as a result of ventricular wall stress and it optimizes the overactivation of this neurohormonal activation systems. So in this case, a lot of BNP is secreted into the blood, which leads to pulmonary and overall vasodilatation, which optimizes the extra and overactivation of this compensatory mechanisms. But in this case, what we can see is that there is a falsely low value of BNP. It should be a very high value. So why this is happening? Because the adipose tissues express natriuretic peptide clearance receptors, which clear the lot of BNP circulating into the blood and sequester it into the adipose tissues. So now we have already discussed that one key clinical insight is that estimation of BNP is a diagnostic limitation in obese individuals undergoing ADHF with cardiogenic shock. And what is the second clinical insight? That in such cases, the clinical assessment and the hemodynamic interpretation is preferred over estimation of biomarkers like BNP, because such estimation of biomarker like BNP can be misleading in that case. So now coming to the exclusion of the wrong options and the selection of the correct one. So option A.
Option A is reduced myocardial synthesis of BNP due to impaired ventricular stretching signaling.
So there is no impairment stretch signaling. The stretch signaling, the ventricular wall stress is releasing a lot of BNP, but it is getting cleared out by the adipose tissue.
Option B, increased renal clearance of BNP in obesity.
So rather the renal dysfunction is leading to an increased BNP levels again in the blood and not a decreased BNP levels.
Option C, analytical interference from circulating muscle derived proteins.
So there is no analytical interference from the skeletal derived muscle proteins.
Option D, enhanced clearance and sequestration of natriuretic peptide by adipose tissue, which is the correct option.
As discussed, this is the correct option.
Option E, cytokine mediated suppression of BNP release in systemic infection.
So again, the cytokine release will lead to again an increased level of BNPs and not a low level.
Search Edumedex on Instagram and YouTube to start your journey today.